This evening, we're with Dr. Andrea DeSimone, and I'm going to turn it over to Christy Hanley with the Sussex County Health Coalition to do the introduction. Thanks, Christy.
Thanks, Tim. Appreciate it. So about our speaker tonight is Dr. Andrea DeSimone, and yes, there is a typo under her name, and I apologize for that. She is the Department Chair, Community Consultation Liaison, Psychiatry attending at Bay Health. With regards to her education, she has a bachelor's degree in neuroscience from Hamilton College, Rowan University School of Osteopathic Medicine, psychiatry residency, where did he go? Thomas Jefferson University Hospital, where she was an academic chief resident, fellowship training and consultation liaison, psychiatry from Brigham and Women's Hospital, Harvard Medical School, board certified by the American Board of Psychiatry and Neurology and American Osteopathic Board of Neurology and Psychiatry. And her career, she's been department chair, community consultation liaison, psychiatry at Bay Health, clinical assistant professor at Philadelphia College of Osteopathic Medicine, chair of Bay Health's Graduate Medical Education's DEI Committee. And some of her leadership and committee positions were at the Medical Society of Delaware, the Psychiatric Society of Delaware, Delaware State Osteopathic Medical Society, Academy of Consultation Liaison Psychiatry, and the Delaware Addiction Action Committee. We would like to welcome Dr. Andrea DeSimone to give us a wonderful presentation regarding psychiatry.
Thank you for that wonderful introduction. I appreciate it. So I am going to share my screen.
And we can see it.
Perfect. Okay. So I am Dr. Andrea DeSimone. I am a consultation liaison psychiatrist, and I'm going to tell you all about what that means. And I will tell you also why I think it is the best of both worlds. So I do want to give a shout out to Dr. Anique Forrester. She's a psychiatrist at the University of Maryland. And so I will give a shout out to her for some inspiration with structure of tonight's talk, as well as some of the de-identified cases. So I do want to start off a little bit with my journey to medicine and how I got here. And this actually starts before college. So I will start at college, but I will take a little bit before college, actually. During high school, I was required to do community service, and my algebra teacher at the time knew that I was a swimmer and liked to swim. So she suggested that I volunteer with Special Swim, and this was Special Olympics, and this was teaching children and adults with special needs how to swim. And I loved it. I thought it was the best thing that I'd ever done. So I thought to myself, okay, maybe I want to be a therapist. Maybe I want to work with people with developmental disability. This sounds awesome. I'm going to do that. So I went off to Hamilton wanting to be a psychologist. And I didn't like my first psychology class. I really didn't like it. And I couldn't quite figure out why. The next semester I took the introductory neuroscience class, and it was called Brain and Behavior. And I was like, this is amazing. I love this. And it really, it talked about both learning the physiology as well as then how that manifested in someone's behavior. So that I thought was the most interesting thing that I had taken. And I found myself like reading the textbook, and I had never done that before, like reading a textbook cover to cover. So I said, okay, maybe this is something I want to do. Over the next couple of years during college, I had a few volunteer experiences or shadowing experiences, and I did work as well. So I worked as a nurse's aide on a cardiopulmonary unit during one summer. I shadowed a psychiatrist, and I volunteered in a drug and alcohol rehab. At the drug and alcohol rehab, I noticed that a lot of the patients that I was seeing had multiple things going on. So they had addiction. That was the thing that they were at rehab to treat. They had a lot of them had a primary psychiatric problem, so things like depression or anxiety, and they also had a lot of medical problems. So they had things like HIV or hepatitis C or uncontrolled diabetes. And so I thought to myself, I can't treat the mind without treating the body. So I guess I'm going to medical school and planning for psychiatry instead of psychology. So at the time I had, Hamilton College is a small college, and at the time you had to take courses in a certain order. So, they only offered physics like 101 in the fall and 102 in the spring. And I had already like messed myself up with taking the classes. So I ended up having to take a couple of years gap year. So during that time, I was 2010 to 2012. I took physics at a local community college to me. I worked as a lifeguard. I did some teaching. I did some swim coaching, and I studied for the MCAT, and then interviewed for medical school. All right. So in 2012, I started at Rowan University School of Osteopathic Medicine. At the time, it was one of the UMDNJs. And while I was interviewing, I found that I really connected with the osteopathic philosophy. So one of the tenets of osteopathic medicine is that structure begets function, and the body is a unit of mind, body, and spirit. And to me, that made total sense. I was like, this is absolutely how I view healthcare and view medicine. So this is where I want to go. I want to go to an osteopathic medical school. So I started in 2012. Towards the end of medical school, a lot of you probably already know this, but you do in the latter half, usually you do your clinical rotations. And so here's where another curveball kind of hit me, because I went into medical school wanting to do psychiatry, and I didn't like my psychiatry rotation. To be fair, I still don't like inpatient psychiatry. I like CL psychiatry much better, and we'll talk about what exactly that is. But I was on an inpatient psychiatry unit, and I really didn't like it because I felt like I wasn't getting enough of that, of the medical part of that. And so you'll hear me, I kind of use the words psychiatry and medicine as two different things. They're not two different things, but within medicine, we tend to classify things as medical, which is more a cerebral, more thinking kind of specialties, and then surgical specialties are more procedural based. So psychiatry, I think of maybe as the third section of that. So I found myself missing medicine while I was on a psychiatry rotation. So I did an elective rotation in hematology and oncology, and I found I really liked that. And I also did some work with geriatrics, which I very much enjoyed as well. So while I was working, or while I was rotating with the hematology and oncology clinic, I found that, I was very intellectually stimulated. Like, treating patients with cancer, you're always on the cutting edge of new developments. So there were reps coming in talking about their new drug. But I found myself gravitating towards patients who were having a difficult time with the cancer diagnosis, or there was some other complicating factor that was getting in the way of them getting to appointments. And so I found myself drifting again back to patients with perhaps psychiatric illness. So I spoke to one of my mentors at the time, who happened to be a psychiatrist, and he said to me, look, I get what you're saying. Why don't you try CL psychiatry? Why don't you do a rotation in CL psychiatry? There's a lot of medicine in CL. So I did a rotation at Thomas Jefferson University Hospital. And within hours of being on the CL service, I said, this is exactly what I want to do. I want to go to psychiatry residency, and I want to do CL psychiatry. So it was like, this is exactly it. It was a great combination of both medicine and psychiatry. And so this is why I think it is the best of both worlds. So next up is residency. So I did end up matching at Jefferson for general adult psychiatry residency. So 2016 to 2020. It's a 4-year residency. So that is while I was in residency, I did a lot of call that was all consultation based. So most of our call intern year and second year was seeing psychiatry consults on the floors. So I got a ton of experience with that. I also got some exposure to some more specialized areas of consultation liaison psychiatry. So things like transplant evaluation. So when people undergo things like a heart transplant or a liver transplant, they have generally, a lot of them have to have a psychiatric evaluation. So I was doing some of those interviews, which I thought was fascinating. I then chose to go on to a CL Psychiatry fellowship. And with CL Psychiatry, if you talk to some psychiatrists, they'll say that, most of the fellowships are optional. I wanted additional training. I wanted that extra training and that subspecialization. So given that it was somewhat optional, I said, I really want to go to a place where I'm going to be exposed to all different types of things that I wasn't exposed to in residency. So I want to be exposed to super niche areas. So I interviewed and matched at Brigham and Women's Hospital and Harvard Medical School for CL Psychiatry. And that's 1 year. It's a 1-year fellowship. So I was there in the middle of the pandemic from 2020 to 2021. So unfortunately, I didn't have a great experience of Boston itself. A lot of things were closed, but I was exposed to many niche areas. So things like burn psychiatry is something I had never done before. My outpatient clinic was in a GI clinic. So I saw patients with inflammatory bowel disease and managed a lot of the same kind of psychiatric illnesses that show up in patients with inflammatory bowel disease. So that was, I got exposure to these super niche, super subspecialized areas. So then it's like, okay, I am finally at the end of this long road of training. What do I want to do? Where do I want to take my first attending position? So first I thought I would take a job in academic medicine. So if you're not familiar with what that means, that's usually at a university hospital where there are medical students, there are psychiatry residents, there's maybe even fellows, and there is a lot of research happening. So that's where my career trajectory was going at that time, because I had been to these big academic hospitals and trained there, and that's what I thought I wanted. And I saw some of the attendings that had graduated a few years, or residents that had graduated a few years ahead of me, and I thought to myself, I actually want to go to a community location. My family had moved to Southern Delaware from New Jersey at that time. And, my mom said to me, hey, they have opened this new hospital near me. Why don't you see if they need a psychiatrist? So they do. Apparently they did. So I took a job at Bay Health, and I am the only attending on the CL Psychiatry service at Bay Health. So I see patients in the medical hospital, and I will tell you a little bit about what that means. So I feel like I've built it up enough at this point. So let's talk about what exactly it is that I do on a daily basis. So what is consultation liaison psychiatry? Well, consultation liaison psychiatry, it's a subspecialty within psychiatry that involves the interface between psychiatry and other medical or surgical specialties. So I am sitting right in the middle, pulling in aspects of all of the specialties. Fellowship trained consultation liaison docs have extra training in a few things. We have extra training in diagnosing and treating psychiatric illnesses in the medically ill, because psychiatric illnesses can look different in patients that are medically ill, and they can present differently. They can be commonly confused with other things. I have extra training in psychopharmacology. So things like, how do I prescribe a medication that is excreted by the liver in someone with liver disease? How do I do that? Or kidney disease, same kind of thing. I have training in medical illnesses with psychiatric sequelae. So medical illnesses that directly result in psychiatric illness. I can help manage countertransference. And so countertransference is a fancy word for the stuff that we feel when we treat patients. So, sometimes if a team is upset with a patient, if a doctor's upset with a patient, I can help them understand what kinds of issues the patient is feeling. So they may be able to better understand what the patient's going through to get a better result for everyone involved. I also have additional training in medical legal issues. A lot of times consultation liaison psychiatrists sit on ethics committees, and we tend to see the most complex patients in the hospital. So we tend to see a lot of the same kinds of cases that have either legal involvement or guardianship. There are some kind of consent issues. We tend to see these kinds of patients. The specialty itself is a relatively new one. It was first recognized in 2003 when it was initially called psychosomatic medicine. Then it underwent a name change in 2018 to consultation liaison psychiatry. So I thought that better captured what exactly it is that we do on a daily basis. Training in CL psychiatry begins in psychiatry residency, and every resident must complete at least 2 months of CL psychiatry. A lot of them complete more of those, but the basic requirement for psychiatrists is to complete 2 months of CL psychiatry. And there is, as I mentioned before, a 1-year fellowship in CL psychiatry that must be completed if you would like to pursue board certification in consultation liaison psychiatry. So in order to truly understand what CL psychiatry is, we first need to define some fancy words. So consultation and liaison. The consultant, that is what I am. I am the consultant. So I'm a person who provides expert advice professionally. So my expert advice is actually to the physicians themselves. My advice, like, yes, I see the patient, but my duty, my responsibility is to the person who is called the consult, and that is to the usually the other attending physician. Then liaison, that is a communication or cooperation that facilitates a close working relationship between people. So it gets to the relationship that the consultant has to the consultee. So how this works in real life is what we say is talk, consult, talk. So what that means is there is a question that a primary team, another doctor has. So they call me and they say, Andrea, I have this patient, XYZ is going on. I say, okay. If I need any follow-up information, I ask them at that point. Then I do the consult, I see the patient, I make my recommendations, and then I talk with them again. I close the loop. So I can explain my recommendations to them because they are the ones enacting the plan. I am simply giving advice. So they're the ones that are enacting my plan. And if there's any new information that's come up, I allow that opportunity for the consultee to tell me all of this new information or discuss, maybe I've missed the mark. Maybe, that's not exactly the question they were asking. So it really creates a closed loop communication. The best CL psychiatrists have these particular interests. So you should want to care for those with significant medical illness and know how these illnesses affect mental health. You have an interest in working with treating physicians to optimize patients' care. So I like to say one of the most difficult aspects of my job is that I sometimes end up being a psychiatrist to other physicians. And we all know that physicians make terrible patients. So it can be challenging sometimes. So you need to want to work with physicians on a daily basis. You must have an interest in educating colleagues, patients, and families about mental illness, how to identify and treat those illnesses in the medically ill, and recognizing psychiatric manifestations of medical illness. And we'll talk about that specifically in a little bit. And you must also have an interest in thinking about the complex care needs for hospitalized patients and how to integrate those better within healthcare. So if you think about it, somebody who is actively psychotic, who maybe now needs cancer care, maybe they need cancer treatment right away. It's very difficult to treat someone who's actively psychotic for a very complex medical illness. So a lot of times I work very closely with medical teams to ensure that patients who have co-occurring psychiatric and medical illness are able to get the best treatment for their illness, for both of their illnesses. Okay, so we work in a variety of settings. So we can work in the hospital, we can work in the ER, and we can work in the clinic. So let's talk about what CL psychiatry might look like in each of these areas. So in the hospital, so I may perform reactive consultations for patients who are admitted to the various services in the hospital. So when I say reactive, what I mean is, the primary team calls me, they say, I have a question Andrea, can you come and see the patient? So it's a reactive, like I respond reactively. Alternatively, I may do something like attend rounds. I can listen to case presentations and suggest which patients might benefit from earlier psychiatric intervention. I might say, hey, listening to you talk about this patient, I think that they would benefit from me seeing them. So that's a proactive psychiatric consultation. I may, at that time, I may offer the team suggestions on how to collaborate more effectively with patients who are, for example, exhibiting behavioral problems that are complicating their medical care. And I may be involved in medical, legal, or ethical consultations, such as evaluating decision-making capacity or participating in an ethics committee. CL psychiatry in the emergency room. So we perform psychiatric consultations in the emergency setting, and these are usually risk assessments, helping to evaluate whether an acute behavioral problem is due to a medical cause, so something like delirium or dementia, or a psychiatric problem, something like depression or schizophrenia, and recommending appropriate treatment or level of care. So when I say level of care, I mean, does this patient meet criteria to go to a psychiatric hospital, or is this something that's more appropriately managed as an outpatient? In the outpatient clinic, CL psychiatrists may have an outpatient practice. A lot of times CL psychiatrists want to see patients with complex medical conditions. And so we can see them the same way we can see them in the hospital. We see, just them as an outpatient. Oftentimes, we're located with an interdisciplinary approach to patient care. So we have access to a variety of services such as social work, nutrition, or case management within that same setting. And we may provide psychiatric consultations and oversight of a large medical setting, so something like a primary care clinic. So we'll listen to case presentations and offer suggestions to the primary care clinicians on how to manage concerns and provide education to the staff about psychiatric illness. So this is, if you've heard about the collaborative care model, a lot of times CL psychiatrists are involved in collaborative care. Okay, so let's talk about the types of psychiatry consults. Most of the things that I see in the hospital can fit into one of 6 categories, and these are the 6. So the first is psychiatric presentations of medical conditions. So the classic example of this is someone who comes into the hospital or who comes into the office and says, I'm really anxious, doc, treat me for my anxiety. I can't sleep at night. I'm so anxious and worried about things. So being the astute physician that you are, you think that thyroid illness can cause anxiety as well. So you run a thyroid panel and you find that the patient is having thyroid dysfunction. Both hyper and hypothyroidism can cause anxiety, but treat this anxiety with an antidepressant or psychotherapy all you want. It's not going to get better if you don't treat the thyroid disease. So this is, a psychiatric presentation of a medical condition. That's what I mean. So then there would be the reverse, a medical presentation of a psychiatric condition. So this is the type of person, the prototypical example is someone who comes in and says, doc, I have chest pain. I think I'm having a heart attack. But what they're really experiencing is intense anxiety or a panic attack, and they feel like they're dying. So that is a medical presentation of a psychiatric condition. I can also see medical complications of psychiatric conditions or treatment. So these are things like neuroleptic malignant syndrome, serotonin syndrome or serotonin toxicity, or extrapyramidal side effects. So these are complications of treating psychiatric illnesses. With neuroleptic malignant syndrome, it's from antipsychotics. With serotonin syndrome, it can be from any number of psychotropic medications. And extrapyramidal side effects are usually seen in antipsychotics. So this might be something that someone is having and they might not know what it is. And a CL psychiatrist can appropriately manage those things in both an acute setting and in an outpatient setting. The fourth one is a psychiatric complication of a medical condition or treatment. So what I think of immediately for this is psychosis in Parkinson's disease. It is very common for patients with Parkinson's disease to have hallucinations, delusions, paranoia, things like that. And that is a direct result of the Parkinson's itself. So this is not somebody hasn't developed schizophrenia, as well as Parkinson's. It is a well-known pathway when somebody has Parkinson's disease that they may develop hallucinations and psychosis towards the latter part of their illness. So this is a direct complication of a medical condition, and it is treated slightly differently because of the pathophysiology of Parkinson's disease. So it's up to a CL psychiatrist to identify that this is happening and to treat it appropriately. I may see comorbid medical and psychiatric conditions. When I think about something like epilepsy and primary psychiatric conditions are very commonly co-diagnosed. So if somebody is having epilepsy, there is a high likelihood that they also have something like depression or anxiety. So I tend to see, in fellowship, we had neurology, a neurology liaison. So when somebody came in for epilepsy monitoring, they were seen by the psychiatry consult team, because we know that there is a high co-occurrence of primary psychiatric problems with epilepsy. And lastly, I could see a psychological reaction to medical conditions or treatment. So this is the classic, what we call a coping with illness, like somebody's having a difficult time dealing with a medical illness. What I think about this, the classic example of this is perhaps somebody who's had a head and neck cancer surgery. They can be particularly disfiguring. Sometimes, whole parts of their jaws are removed, or mastectomy for breast cancer, what that means in terms of their identity. This can be very difficult for people to undergo sometimes disfiguring medical procedures. So sometimes people have gone their whole life without having depression or anxiety, and now that they're in the midst of treatment, they're having symptoms. So I may be called to help with that. So let's talk about some sample cases. So these are all de-identified, then they're amalgamations. So I do want to be clear on that. These are not real cases. So Miss Smith is a 32-year-old woman with no significant past medical history. She had severe constipation and occasional rectal bleeding for about 2 years. She was then seen in the ER with severe abdominal pain, and the workup at that point revealed rectal cancer. She is currently undergoing biweekly chemotherapy and has continued issues with treatment noncompliance. The oncology team consults psychiatry to evaluate her for depression as a possible cause for her noncompliance. So right away, we'll talk exactly what the major depression is, but just from this, we don't really have a good idea of what psychiatric symptoms she's having. Could this be, as we talked about before, could this be a symptom of her illness? Could it be a side effect of the chemotherapy? Is she having difficulty coping, which can look an awful lot like depression when it's not treated. So first, knowledge of non-psychiatric causes of depression may guide your workup. So first off, taking a look at the medical causes of depression, I won't read all of these to you, I will spare you, but cancer is one of them. Cancer in and of itself can cause depression. And then these are not, I want to be clear that these are not diagnoses that are particularly difficult to have, though a lot of them are, and the reaction to the illness is what causes the depression. No, these illnesses themselves can perpetuate depression, can induce depression through pathophysiologic mechanisms. Medications that may cause depression, taking the medication itself. And we have a bunch of chemotherapeutic agents on here as well. And I also see that there are anti-Parkinsonian drugs. Those medications for Parkinson's disease may cause depression themselves. Right? So these are the things that consultation liaison psychiatrists start to piece together. This is a very complex picture for a lot of these patients. Major depressive disorder itself is more complex than SIGI-CAPS, but it is a good start. And so we will start there. So SIGI-CAPS is how we remember the diagnostic criteria for major depressive disorder. So that stands for sleep disturbance, decrease in interest, feelings of guilt or worthlessness, decrease in energy, decrease in concentration, a change in appetite, psychomotor changes, and suicidal thoughts or thoughts of death. And so you notice that I have sleep disturbance and appetite disturbance in a different color. And so that means they can be either increased or decreased in major depression, and that would still meet criteria. So when I say anhedonia, I mean just a feeling of loss of pleasure, that nothing, that things that used to give people joy no longer give them joy. So the clinical criteria for major depressive disorder is 5 of 9 of these symptoms that happen more days than not for 2 weeks or more. And it causes clinically significant distress or impairment in their functionality. So are they saying, these are really severe symptoms. I can't function. I can't go to work. I can't do my usual routine. And they're not attributable to substance use or another medical condition. Okay. So if we talk about coping with illness, coping can look a lot like this, right? Which may look a bit like depression to the untrained eye, right? So think about what you look like when you're sick, right? We all regress. We all do this kind of a thing when we're sick, right? So, you're feeling like crap. You have a warm blankie. You've got a warm blankie that maybe, you've got a warm and fuzzy blanket. You've got a drink, you've got a snacky, and oftentimes that's junk food, right? We're not, eating healthy things when we're feeling sick. Your room is messy. There's tissues and like discarded food stuff everywhere. You look, upset. You have a sourpuss on your face. And if patients are in the hospital, a lot of times there's like a pillow from home or a stuffed animal from home or some kind of trinket that reminds them of home. A lot of times in the hospital, you'll see patients watching TV constantly. And so these are adults and they're watching maybe cartoons, maybe Nickelodeon's on, or maybe the Disney Channel's on. Like they're watching children's shows, which, I mean, I get it. Children's shows are great, right? But I see it all the time when people regress to an earlier developmental stage. Their lights may be off. And they don't want to get up and get out of bed now. And I don't want to, people have heard about this, right? With the rise of the man flu, right? Like social media has brought the man flu to attention, right? But this could be a developmentally a good thing, right? Because when we're sick and we kind of look pathetic, that's when people want to take care of us. So it evokes a caring response in our friends, our relatives, and the nurses that are on the floors, right? They want to bring you the warm blankie. They'll rub your back when you're crying, things like that. It can be helpful to evoke the care that we need, but it can also get in the way. So we're starting to think that maybe some of this patient's of Miss Smith's coping is not quite, maybe is a barrier to her getting appropriate treatment. So on interview, Miss Smith says, I don't know why they're so upset. It's my body. The chemotherapy makes me sick. I feel better when I miss treatments here and there, but I do want to get better. Her history reveals that she has no significant past psychiatric history, but has an extensive history of sexual trauma. She denies prior and current psychiatric symptoms, and she has a very limited support system, and she's currently unemployed. So thinking about this case after we've interviewed her, so there's a lot of things going on, right? So she's young, she's in her early 30s. She has a cancer that needs chemotherapy. That's very difficult for anybody, but particularly in a young person who may not expect to get sick, right? Doctors also tend to expect patients to be really good patients, or if not, the perfect patient, right? We tend to expect patients to get to their appointments on time, to go to all their appointments without fail. We expect perfection from them. And that's a lot of times not a reasonable expectation. Is she having any difficulty getting transportation? She's unemployed, has a limited support system. Can she get herself to the infusion center? We're starting to see that medications for depression may not quite get to what is going on here. And the last thing that I want to think about is that she has a rectal cancer and she has an extensive history of sexual trauma. Now that is a very sensitive area. So she may have ideas about why she got rectal cancer and whose fault it might be. Could it be her fault? Could it be someone else's fault? So there are a lot of things that are unsaid that we need some answers on. All right, moving on to sample case number 2. The Mrs. Jones is a 62-year-old woman. She has a history of lupus. She has no prior psychiatric history. She comes in and she is paranoid. She's delusional. She reports that there's cancer all over her body. She is agitated. She's hyper-religious and hypersexual. The emergency department team has concern for lupus erythritis, but she is too altered to undergo any kind of testing for that. The ER and rheumatology consult psychiatry for assistance with behavioral management. So things to note with this case. So these things are totally out of character for her. And this came on quickly, which means that this isn't likely to be due to a primary psychiatric illness. This is likely, as the ER thinks, is due to something like, more likely due to something like lupus erythritis. Though I like to say, with psychiatry, nothing is fast in psychiatry. Everything is slow. Things don't come on overnight. So when things do happen overnight, it's likely a primary medical problem. So in thinking about how to treat agitation, so the call that you're going to get and that I get to come see a patient is the patient's agitated. That's what people will say to me. And that could mean many different things. That could mean, when we actually talk to the team or see the patient, it could just mean that they're repeating questions over and over again. They could be pacing. They could be restless. They could be aggressive. They could just be yelling or speaking loudly. I've had that too, where somebody was very deaf and was speaking very loudly. They could be crying, which may be an appropriate psychological reaction, but we then start to think about this countertransference thing again, which maybe that's making some of the team uncomfortable. So then they view it as agitation and the psychiatrist needs to come and fix them, right? So this is a little bit more complicated than the patient is agitated. So when I'm treating something like agitation, what I tend to view is I view it as turning down the volume, because a lot of times when patients are agitated, both the patient may be loud as well as the staff. So I need to have the patient calm to allow me to examine the patient and gather more data about what may actually be causing the agitation. We have many options available to us. And so when I make recommendations for this, I use mild, moderate, and severe agitation, and I try them and I use them appropriately. I like to say to people when I'm discussing it with them, like, mild agitation does not need a medication. I feel like I can be mildly agitated on a daily basis. I don't need a medication. But you want to think about moderate and severe agitation and what those recommendations might be. One option for this is a pharmacologic agent to treat agitation. And my goal with this is to rapidly calm the patient without over-sedation. I am trying to make them calm and awake. I am not trying to make them go to sleep. I prefer non-invasive over invasive methods whenever possible. So if it's possible for a patient to take a medication by mouth, I want them to do that. I don't want to give them an injection or a shot of something. I want them to take it by mouth if they can. And I keep the cause of agitation in mind as I choose from my options, because there are some medications that may be good for one type of agitation, but not so good for another. And I'm always balancing patient and staff safety. That is always something that I'm keeping in the back of my mind. I have to keep both of those things at the forefront. So for this sample case too, the medical workup for this woman includes an LP with sedation. She has to get sedated, and LP is something that needs careful precision. They need to draw an ANA. This will help us determine about the extent of the lupus. And she had a CT and an MRI with contrast, and that showed small vessel disease, but no acute findings. And rheumatology recommended steroids, so 1 gram of methylprednisolone with some improvement per the spouse. Psychiatry recommended to start quetiapine for psychotic symptoms, and eventually the patient was discharged home with a plan to taper both the quetiapine and the steroids. Okay, so the third one. So Mr. Johnson is a 26-year-old male who identifies as a man who has sex with men. He was diagnosed with HIV in 2011. And he has not been on HAART, so he hasn't been on a retroviral therapy for the HIV in 9 months, and this is his 3rd clinic. He presents to the clinic to restart medications. He has a history of sexual and physical abuse in childhood. He smokes cannabis daily, occasionally uses cocaine, and he has unstable housing. He's currently unemployed, no family supports, and receives food stamps. He is referred to psychiatry for evaluation for depression and substance use. So, having already talked about the criteria for major depression, there are some things about this history that raises that maybe casts a little bit of doubt that there is depression happening. We don't quite know, but I want to think about any of the non-psychiatric causes of this patient's depression or symptoms, let's say. One of the major things that I want to focus on, especially for patients with chronic psychiatric illness, is social determinants of mental health. We see them a lot with social determinants of health, but we specifically have ones for mental health. So this is the conditions and the environments where people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. So first we think of things like societal problems. So adverse childhood experiences, which we know he has had, any racism or social exclusion, and the exposure to violence or criminal justice involvement. I next think about socioeconomic status and opportunities for accruing wealth. So does he have low educational attainment, any unemployment, income inequity? Is there neighborhood poverty where he grew up? In terms of the immediate and global physical environment that he lives in, is there neighborhood disorder? Is there pollution? What has the relationship been to global climate change, and what has the impact been on the area where he lives? And we can't forget about basic needs. So housing, food, transportation, and healthcare. Is there housing instability, food insecurity, or poor access to transportation or healthcare? All of these things can determine whether a patient is, I guess, fighting an uphill battle in terms of their mental health versus people that may not have some of these barriers that are not fixed with psychotherapy or with a medication. So we do need to talk about the relationship between substance use and mental health with this patient as well. So he's using both cocaine and cannabis. So first, let's talk about cocaine. So how cocaine works and how it impacts mental health. So cocaine blocks dopamine reuptake transporters, and it has this rapid, intense increase in dopamine concentration, so like really feel-good chemicals, followed by a sharp drop. So the intoxication could be very euphoric, but it also, the downside of the intoxication could be agitation, paranoia, or anxiety. Then there's the crash, the sharp drop in the dopamine, which can result in depression, anxiety, or cravings for additional cocaine. Thinking about cannabis, in terms of intoxication can cause relaxation or feelings of euphoria, but it also can cause depression, anxiety, and psychosis on its own. It has an unpredictable course depending on the route of administration, the dose, or the strain of cannabis that somebody is using. And word of caution for cannabis use, there are interactions with many commonly used medications, including retroviral therapy. And the dispensary employees, a lot of times people will say to me, well, you don't have to worry about me. I get my cannabis from the dispensary. The dispensary employees are salespeople. They are not prescribers. So they are trying to sell you something. So they are not, they are not well-versed in how cannabis may interact with another medication that you may be taking. And there are no standards with the chemical makeup of the products. Okay. So with this case, the main concerns for this patient are applying for disability and the lack of stable housing for him. He doesn't feel like cannabis is a problem and declines substance abuse treatment at that point. He does admit to feeling occasionally depressed and isolated, but denies suicidal ideation. He improves regarding medical visits, but still misses his psychiatry appointments on a regular basis. He was started on an antidepressant, but showed limited improvement with the antidepressant. Intermittently is positive for cocaine, but usually always positive for cannabis. Eventually, he accepts substance abuse treatment. His adherence to HART improves, but still misses appointments occasionally. So this is something else that I want to underscore again, is that, a lot of times physicians expect our patients to be perfect, but that may not be a goal for all of our patients. I don't think it should be perfection should be a goal. This is improvement for this particular patient. It is not perfection, but it is solid progress. Things go slowly in psychiatry, and we just should not hold our patients to this unrealistic standard. So sample case number 4, last one for us. Miss Harris is a 75-year-old woman. She has type 2 diabetes. She's got peripheral vascular disease, and she is admitted with a gangrenous ulcer on her right foot. Surgery recommends a BKA, below the knee amputation for this. She declined, stating she has lived long enough and wants to die with her body intact. Her daughter reports she's increasingly confused over the last year and is now concerned for depression. Psychiatry is consulted to assess the patient's capacity to refuse the below-the-knee amputation. So this is one of those medical, legal, or ethical cases that I'm involved in very frequently. When we think about capacity and the ability to make a certain medical decision, I think about it on a sliding scale. So on the y-axis, I've got the relative amount of cognitive ability required versus the risk of harm on the x-axis. So something very, very low risk, like a decision to decline compression boots. This is to prevent blood clots. The decision to decline those is, how much do we think the risk of blood clots is for, one day of not wearing the compression boots? Probably not very high. So the amount of cognitive ability required to decline those is very, very low. It starts to creep up a little bit when we think about the decision to consent to an LVAD. An LVAD is a left ventricular assist device, and it comes with a significant lifestyle change with it. There are things like you can't be submerged in water. So if you like to go swimming, that you will not be able to do that once you have an LVAD. So the decision to consent to that is a bit higher. And where we kind of are here is the decision to decline an amputation in the setting of osteomyelitis, right? So this is something that we think that if the patient does not have, that they're actively declining, they could pass from this. So this is a significant issue. And if she is declining, if she is going to the experts and saying, she's come to the hospital and said, give me your recommendation, I want to know that you're able to think and wrestle with that decision and come to your own choice in a logical fashion. So there are 4 things that a patient needs to be able to demonstrate to have decision-making capacity to make a decision. And I will say, and I say this over and over again, with physicians, and particular psychiatrists, we are examining patients one decision at a time, right? So first, they need to be able to communicate a choice. I need for them to be able to tell me what their choice is, whether it's written out or whether it's by words. I need for them to communicate a choice to me. I need for them to demonstrate their understanding of the relevant information. I need for them to appreciate the situation and its consequences. And they need to demonstrate that they can reason about the treatment options. So with this particular patient's case, let me see if I can move us. Here we are. Okay. So for communicating a choice, she says, I don't want them to cut off my foot. I don't know how many times I have to tell you I'm not having it done. You can't make me do it. So it sounds like she is communicating a consistent choice to the staff. For understanding relevant information, what she says is, the doctor told me that I have an infection on my foot and they need to cut off my foot to cure it. I think about a lot of times, is the patient's understanding appropriate to their level of education? And somebody who's not in healthcare, if they're able to say, I have an infection in my foot and they need to amputate it, that to me is pretty good. It's pretty good understanding. So can she appreciate the situation and its consequences? She says, I know I've got an infection. It's been there for a while. I know that. It's really painful. The treatment may cure it, but I don't want to live with my foot cut off. So just give me pain medications and I'll be okay. Okay. So this, I'm starting to think like, well, maybe like it seems, there are some things that we can do for people who don't have limbs. Like maybe, this is not the first time this has happened. There are plenty of people who lead fulfilling lives who are amputees. What about this particular issue is so limiting for this patient? So when we talk to her a little bit more, she says, I'm really worried about the surgery. What would happen if something went wrong? I'd die anyway. Then what will I do about getting around? They're not going to give a new foot to an old lady like me. How will I play with my grandkids? And what about the pain after? It will be unbearable. I would just be better off if I died with my foot attached. So it sounds like at this point, there may be some anxiety that is a barrier to accepting treatment. So I can ask the primary surgical and pain management teams to speak with the patient in more detail about what exactly will happen and what they can do. Physical therapy and occupational therapy can discuss a plan for therapy and how she will be mobile when she leaves the hospital. And involving the family in discussion is key for something like this. And so I'm specifically going to, I didn't have an ending to this case, because it's not about making the patient do one thing or another. It is about understanding the patient's thought process behind their decision. And if this is right for them, then it's right for them. I just need to understand if they have thought it through, and if they're making their decision based in logic and reasoning. So that is all I've got for the didactic portion. So I will stop sharing. And I have talked long enough. So I am happy to take some questions about all of the stuff that I've given you on this whirlwind tour through CL Psychiatry.
All right, thank you very much. Well, I'll start us off. Why do we not use the term co-diagnoses instead of comorbidities?
That's a great question. I agree with that. I will counter by saying we call it dual diagnosis a lot of times in the biz. So when I recommend patients go to inpatient psychiatry and they have and they have maybe a substance use disorder as well as a primary psychiatric disorder, the units are called dual diagnosis units. And then the other thing that I think about is there are units that are called med psych units. So that means somebody's got both a medical problem and a psychiatric problem that is being treated. I don't know why specifically we say comorbid. It's probably like most things in medicine. It was done at a time where we didn't think about what these things meant, and it's just continued on. But I agree with you, co-diagnosis or multiple diagnoses or complex care needs is definitely a nicer way to say exactly what we mean.
Right. And then for people who aren't in the profession, there's the was it the Morbidity and Mortality
Yes.
journal? Such an uplifting periodical. Anyway, if I am diagnosed with a mental illness, can I become a doctor?
Yes, absolutely. The short answer is absolutely yes. So, and I have some interesting or like fun facts to back this up. So, I think when people talk about or like worry about if their psychiatric treatment is going to like follow them or haunt them throughout their medical career, they think about the licensing paperwork for various states. And some states, I am not totally up on which ones still remain, but some of them say things like, have you ever been diagnosed with a psychiatric condition? Have you ever been diagnosed with a substance abuse disorder? I will say most of them do not say that. I can't tell you how many exactly, but I can tell you for a fact that Delaware specifically removed that question from their licensing paperwork very recently. And I actually have it quoted on a list of resources that I've made specifically for physicians for finding psychiatric care. I've like quoted the verbiage in it. And so it's like they will never ask about treatment for people who have controlled psychiatric illness.
Right.
So most of the remaining questions that are on the advocates for this want to remove them entirely, which I totally support. But most of the remaining questions are phrased as things like, do you have an uncontrolled substance use disorder? Do you have an uncontrolled psychiatric illness that prevents you from doing the duties of a physician? Or do you have an illness that prevents you from doing that, medical or otherwise? And so those, I think that physicians should feel empowered to check the box no if they are actively seeking treatment for their psychiatric illness, depression, anxiety, bipolar disorder. I think they should absolutely feel empowered to check no, because they're doing exactly what they're supposed to be doing. You wouldn't check that box for appropriately managed diabetes. So why would you check that box for appropriately managed depression or anxiety? So, I mean, clearly I'm biased. I'm the psychiatrist talking about this. But the short answer is absolutely, of course you can.
All right. So how hard is it to have someone declared incompetent or in need of guardianship?
Oh boy. Okay. So how hard is it? I guess, well, okay. So this, I can tell you the process, and I guess you can tell me how hard you think it is. I think it's generally pretty hard because we don't want to do it, because we don't want to remove somebody's autonomy. I can tell you, in the hospital, we do everything we can to avoid guardianships. Absolutely, 100%. We try to avoid this at all costs. Maybe most of the reason is because it means that the patient's going to be in the hospital a long time, and it costs us a bed stay for months. But also it's just not right to do for someone who doesn't need it. So generally, if there is going to be a case where the team is thinking about guardianship, they're calling me for it. So generally, the anybody in the let's not say anybody. No, don't remember that. Any physician can do a capacity evaluation. So now, capacity and competency are two different things. The physician can determine capacity for a single decision. That's why I say single decision. Competency is for multiple decisions. So that's when you say incompetent. And so that's for all decisions, right? That is out of the scope of physicians. No physician can do that. That is a job for lawyers and a judge. And that's when the patient has the right to have their own representation at that hearing, right? It is difficult for the patient themselves to be at the hearing if they are in the hospital. I totally get that. But they are able to hire their own attorney. And that has happened. So what the process is a lot of times it's something like capacity to, I guess, decline a nursing home referral. So I get that a lot. So we think that some of the primary team thinks that the person is not able to live on their own anymore. They were found down. They were down for 4 days before their neighbor noticed that their mail was piling up and found them passed out on the floor in their kitchen. So that's the kind of the thing that we usually see is the patient, the primary team thinks that the patient's not able to live on their own anymore. So they make a recommendation to go to a nursing home, and the patient says, absolutely not, I'm not doing that. Thank you, get out. So they need to, the primary attending needs to do an evaluation. They need to do one and say that they don't think that the person is able to demonstrate the capacity to refuse their recommendation. And then most of the times they call me to back them up. And I like for them to do that, especially with guardianship cases, because if it goes to court, if the person fights the guardianship and says, no, I don't agree with this decision, the attendings, the medicine doctor's note is going to be, available from the lawyers, as well as my note. And I need to make sure that if I'm, doing something that takes a person's right to their own autonomy away, that it better be done appropriately. So most of the time in these situations, it is a question of a cognitive disorder. So I will do something called the MOCA, which if you were following the news several years ago, I think it was the 2020 election, maybe it's 2016, I don't know. But Trump said that he did so well on this test. That's the one I give to my patients. And so I will give this test to the patient, and it's a good marker of, it's a good screening test for a dementia, for a cognitive concern. And so that can tell me what exactly, like why I think that the patient might be not able to make this particular decision. So I do the examination, I speak to them. A lot of times I speak to family members if they're available. I ask them how they're doing how they're functioning. The primary team will also call physical therapy and occupational therapy. So I will have that information a lot of times as well. So I will say things like, it sounds like the physical therapist recommended that you go to rehab. What do you think about that? And I want them to be able to say, like, there's a risk I could fall and pass out in my kitchen and I could die. Like, that's what I want them to say, like very simply. And if they're not able to engage with that kind of a discussion, then I wonder if they're really truly able to appreciate the risks. I am absolutely okay. Yes, thank you, Mocha Cognition. I am absolutely happy to have somebody make what I think is a bad decision, if that's what's in line with their beliefs. But I need to know that you know the risks of making that poor decision. So my examination happens. There is we may overlap with physical therapy and occupational therapy. And then there's something called the physician's affidavit. And I don't fill that out. The primary attending fills that out. And that is something that we view as like, patient. So like occupational therapy will help them, like will, have you say like, make me a peanut butter and jelly sandwich. Like we'll test their ability to like make food for themselves, or like, can they operate a microwave to heat stuff up? Can they write a check to pay their own bills? Can they manage their own medications? So they'll have all of these things there. And so all that goes into this document, this physician's affidavit that summarizes all of our thoughts. And then that gets submitted to the court. There are some additional steps in there, of course, but that is what then is argued by the hospital attorneys to support the physician's the position on this. So then it's out of our hands and is argued in a court of law. So if I say we can do this emergently, emergent guardianship is a thing, we can do it, but most guardianships are not emergent, so it takes months. So I would say it's not easy just because of the amount of time and energy and attention it needs. But I can absolutely see how from an outsider's perspective, it's like, well, just two physicians say this and like then it goes to court. It's like there's a lot of stuff in between there, and we actively try to avoid that. So if there is any family member who is willing to, or somebody that they say like, I would like my niece, my so-and-so to manage my money or to manage my medical decisions, that's what we're doing. Like we're absolutely trying to keep it out of the courts, because who is going to make a best decision for somebody other than their loved one? Like that's the best chance that we've got. So it's a long and drawn out process for guardianship, but I can tell you we actively try to avoid doing it.
Yeah, all righty. Thank you. Have you evaluated pregnant women for depression or women with postpartum symptoms?
Mm-hmm. Yeah, of course. Yeah, that is absolutely something that we do.
And in those cases, is there a frequent treatment program that works for most?
I guess I think about how severe are we talking? So I think about that too. So someone with postpartum psychosis, I am worried about immediately. Like that's one of the only things that I think is a psychiatric emergency. I want to get that person into treatment immediately. It's a high risk to themselves and the baby. So that I really very much want them in inpatient treatment pretty quickly, because I want to do a fast medication titration. I want to do it fast because we're at a point where this is an emergency. For I don't want to say usual, because I mean, that maybe, I don't know, but the typical, I want to say like run of the mill postpartum depression, that is treated exactly the same. I don't say exactly the same, but mostly the same as regular old depression. We are just mindful if the woman is breastfeeding, we're mindful of the medications that we give because they end up in breast milk. So I'm mindful of those medications. However, some women are not breastfeeding, and that's okay. And so then I have the full complement of medications available to me. There's some newer treatments, and I will tell you, I'm not as well versed on this because we don't have it in the hospital, so I don't see it a lot. But there's some novel agents for postpartum depression that I believe are infusion that are used. There were some people using it in like on the main line and or like administering it on the main line in Pennsylvania. So there are some newer stuff, brexanolone, I think that's the name of it. But there are some newer therapies for that. But usually it's just what you treat regular old depression with.
Right. Okay. Are there diagnostic imagery equipment that can be used to make mental health diagnoses?
I think if you asked the majority of psychiatrists, you would say no. They would say no. There is some. I will qualify it and say that it's generally viewed as kind of fringy views that maybe SPECT imaging can predict psychiatric illness. But generally, most psychiatrists, if the majority of psychiatrists that you would ask, they would say no.
Okay. All righty. I'm going to say this question and I'm not quite sure. We might have to redirect it. Are there more cases for psychiatric patients with mental health issues?
Yeah, I need a little clarity on
Yeah.
that.
Ori Brooks, that was your question. Can you restate that question again in the chat for us, please? This is another question regarding the ability to practice as a physician. Would having self-inflicted scars affect whether or not someone is hired as a physician?
I'd argue it shouldn't. But will it? I don't know. That's a toughie. Should it? No. I mean, if they're recent, perhaps that may cause some concerns, but scarring doesn't go away. So, you know, that may be, if it's remote, that may be, you know, I don't see why it should. But.
Well, in a time when tattoos and piercings are so prevalent, scarification can have ceremonial. I mean, it's not just self-harm.
Mm-hmm.
Yeah, interesting. How do you get oh, this is a good question. How do you get over the hurdles of a family member with dementia and or Alzheimer's?
Oh, I mean, like logical ones, or like, I don't want to say logical ones. I don't mean logical. I mean like practical. That's what I mean. That's the word I'm searching for. Like practical ones or emotional ones. Some of the treating somebody with dementia is very, very difficult. Being a primary caregiver for somebody with dementia is incredibly difficult. So, you know, a lot of the things that I think about, you know, when patients' families ask me about this kind of a question, you know, they say like, well, I want to keep them at home. I don't want to put them in a home. I don't want to put them in a nursing home. But this is really, really difficult. And I tell them like, look, this is a you, not, I don't want to say this is a you decision, but like, this is your, like, I can't tell you what to do. Like, this is an immensely personal thing, but you know, I can tell you that some people will say to me, they are staying home at all costs. they're my family member. They are staying here with me. I will get home care. I will get, home health aides. Like, this is what we're going to do. We're going to have everything here in the house for them. And I can, on the other hand, there are people who say like, no, I want them to be with other people, I want them to be with skilled caregivers who are giving them music therapy throughout the day. I want them to have interaction with other people. So you can make that argument that people living in a supportive environment, who are able to walk around, a lot of times physical issues are not, are less of an issue than the cognitive ones. So people can do quite well in a supportive and structured living environment. I have, friends who say that their loved one is thriving. So this is an immensely personal decision. And there is, if this is based in a situation that you're currently in, I've heard that the book, The 36-Hour Day, I think that's the name of it, The 36-Hour Day, was very helpful for a very close friend of mine who had a mom with early onset Alzheimer's. And so she told me personally that book was so helpful for her. So that would be something that I have recommended to people.
Interesting. Okay, let me see whether I can interpret this question. If someone's inpatient and the hospitalist and a PCP disagree on the patient status or diagnosis, who wins?
Well, if it's the hospitalist and the PCP, the hospital is only going to see the patient while they're inpatient. So primary care wins. Because if you're seeing the patient longitudinally, right? Like the primary care doc is going to be treating the patient for a longer amount of time than the hospitalist is, right? So I guess the other thing that I think about with this question is, it is not unheard of that two consultants consulted for the same patient for the same thing may have vastly different recommendations. So this happens a lot with cards and renal. You can look up some very impressively done Glaucom Flecken videos about cardiology fighting with renal. It is very common for us to disagree because we're looking at the patient from two very different lenses. So that's the role of the primary team or the hospitalist, is to gather this information from the consultants that they've called, and either make us talk to each other or make a choice of who they want to go with. So that's why I will tell primary teams, like, be cautious of consulting two different services for the same question, because you may get conflicting results. And then what do you do, right? You should never order a consult without having a good idea of what you want from it, just like you wouldn't order a lab test, without having an idea of what you would do if it was high, if it was low, if it was normal.
Right. Okay, this is the chicken and the egg question.
Okay.
In those cases, do psychiatric conditions cause medical conditions, or the other way around?
Yes.
Eating.
It is so intertwined. Yeah, so intertwined. It's so difficult to say. So we can talk about, even going as far as like nutrition. Like I'm actually doing a project right now about how nutrition can induce psychiatric illness, or poor nutrition can induce psychiatric illness. So we think about things like chronic inflammation. That's a known etiology of depression. So we think about it, like it's, if it's like, what's the first insult? I'm not sure which one it is, but the presence of the two of them, then there is a feedback loop, and it, one begets the other, or one supports the other. So I say, let me think about the most. I don't know if I could say if I see one or the other. I guess this is what I will say, as I tend to be people tend to call psychiatry for things that look like psychiatry, right? So I tend to be called for people that have chronic mental illness and all that looks like, right? If you think of somebody with schizophrenia that's uncontrolled for many years, you have an idea in your mind about what that looks like. And so I tend to get called for these kinds of cases. So I think if I had to choose one, I see more primary psychiatric syndrome, but I think we're missing a ton of illnesses that are caused by primary medical illnesses, like diabetes, metabolic syndrome. Like it's chronic inflammation, it's chronic, like there's issues with oxidation. What else have I talked about? Like the HPA axis. Like we could talk all about these things, these like chronic stressors that are happening with these chronic mental illnesses. And it's like the Lexapro isn't touching them. I shouldn't say that. They're not paying me. The escitalopram is not working well. The bupropion is not working well. And it's like, I kind of wonder why. It's because their diabetes is not well controlled. You know, so sometimes it's psychiatry fix their depression so I can treat their diabetes. It's like, we both have to work in tandem.
Right, right,
So it's both.
right. Now that's a fair answer to a very complex question. Sort of getting back to the trajectory of education, do you need to attend a really good undergrad school in order to get into the kind of program that will allow you to be a great psychiatric specialist?
I will say no. And I will, and I mean, I guess what is a great school? I don't know. It's a complicated, loaded question, because it gets to things like, it gets to, questions of DEI, right? Because I'm thinking my first thought is, well, I mean, you know, in my medical school class, I went to a state school, essentially, like it's the state osteopath at the time, it was a state osteopathic medical school, right? And most of my classmates, a large portion of my classmates went to state undergrads. Went to Rutgers, TCNJ, you know, that's where they went. They went to public, you know, to public and like local private institutions. When you go to, I guess, larger Ivies, you can absolutely see that they tend to pick students from the same places, right? Which I totally I see as an issue. That's the kind of thing that I think your question is getting to. That being said, as the advice that I received when I was applying to medical schools, the advice that I got was the best medical school is the one that accepts you. And that I think is the main thing, is getting into medical school to get your foot in the door. But yeah, any medical school will prepare you, will prepare the right person, right? If you are looking for, you know, an academic or a large academic, you know, I will say that academic medicine is not the be all and end all, right? Like I've been to both kinds, and it's really not the be all and end all for like good patient care. But if that's something that you're wanting to do, how I got my foot in the door was doing an audition rotation. And yes, there is luck there. Like I happened to find myself on service with somebody who sat on the residency recruitment committee. So there is substantial luck there. So yeah. I would say do an audition rotation at a place where you want to go to. And so that can help, you know, maybe like a, I don't know, like not an Ivy, stand out a bit more with your work ethic and how teachable you are. Like that's what they're looking for, right? Nobody is looking for perfection in a resident. They want to know if you're teachable. They want to know if they teach you something that you will, listen to what they say and go look it up and, show interest. And so that's what programs are looking for. So the short answer is no, but I mean, I have spoken to people on admission committees or I guess residency recruitment committees and say they don't look at DOs for their Ivy League program. And I'm like, well, that's really a shame because you're ignoring a large chunk of physicians. It's still seen. But there are certainly very good programs that will graduate very good psychiatrists. And that those are usually the outliers, the ones that are like, oh, we don't want to look at DOs, or you need like a, whatever a top score of the USMLE is. I have no idea, actually. Like we only look at those. Those are in the rare form. I think psychiatry is much better at looking at a whole person, because we're looking for people who can treat people. Like it's an immensely personal area of medicine. So that's who we're looking for people who can connect with other people.
So I'll read this verbatim. I think I know what the person's asking. If you've had mental health care in the past and all you got out of it was a cheerleader,
oh no,
or you, the patient, does that mean you may not need help, or you had a poor therapist?
That one. That second one. I tell patients, psychotherapy is supposed to be hard. That's why I don't recommend it to everyone. And it's not something that I like. Generally, most patients I recommend psychotherapy because it's the best treatment a lot of times for what I see. But there are some patients who I don't recommend it because I know that it can open up some stuff that they're maybe not ready to deal with, and so it would be doing them a disservice. So when patients tell me like, all I felt was like I just talked to them and they didn't say anything, or they didn't it just felt like I was talking to a friend. Like that's not a therapist. A therapist is somebody, it's supposed to be hard. There are some times that you will feel worse after the therapy session, and that's why you have to be at least able to tolerate feeling badly sometimes. I just talked about a really traumatic thing. Like, what am I going to do to cope with that? Like, I can go for a walk, I can work out, I can do all sorts of things. You have to have, something that you can do. So psychotherapy should be challenging, and the person should be helping you learn about yourself, and that's through their own inquiry. So, I noticed that, you have this goal and you're still doing this. Like somebody who, I hear it a lot with like life coaches or something like that. Like, when they say somebody who wants to lose weight, it's like, well, if you're seeing a therapist, you don't need to know that, you don't need for somebody to tell you that you should lose weight or how to lose weight. Most of the time, most people know what to do, but yet they're not doing it. And so that's where the therapist comes in, is saying, hey, you have this goal and you're not able to do the things that you say you want to do. So what is getting in the way? Like, let's understand that. So yeah, the therapist should not be a cheerleader. They should be challenging you and helping you work towards whatever goals that you've got.
All right. Really great question just came in. To the layperson, what's the difference between a psychologist and a psychiatrist and the care that they offer?
My cheeky answer is $200,000 for medical school. Because the PhDs get paid for their graduate work. I don't get paid to go to medical school. But in all seriousness, so a psychologist is somebody who is a PhD or a PsyD. So those are both psychologists, and their main function is psychotherapy. Or if you're a PhD, you may do research or things like that as well. A lot of PsyDs do research as well, but a PhD track is more like a scholar researcher kind of track. You may see patients, you may do a lot of clinical work, but traditionally a PhD psychologist is doing more academic and scholarly inquiry. A PsyD is somebody who is going to graduate school for psychology with the intention of being a clinical psychologist. And so that's the focus of their graduate program. So their graduate programs may not have as much of an emphasis on something like research methods, where you would find that all over a PhD program. A psychiatrist, think of a psychiatrist as a doctor with a specialty in psychiatry, much like a cardiologist is a doctor, as a physician with a specialty in hearts. So that's the way to think about what the difference is. So I'm a physician first. That's if somebody asks me what I do, a lot of times I will say I'm a physician. So I'm a physician first. I'm always looking at my patients through the lens of being a physician. A psychologist is looking at their patients through the lens of being a psychologist and a clinician. So they don't have a medical background. That being said, so if you think about the two types of care that a psychiatrist and a psychologist offer, a psychiatrist these days, and you tend to find more psychiatrists doing this, are just medications. However, psychiatrists are trained as well in psychotherapy. So there are many psychiatrists that do their own psychotherapy. So you can see a psychiatrist maybe at this week for medications, and then you see them for psychotherapy for the remaining weeks, things like that. A psychologist does not prescribe medications. They only or just do psychotherapy. So if they think that you may benefit from a medication, they would need to send you to a physician who can prescribe. Now, in the state of Delaware, we don't have a ton of psychiatrists, so a lot of times that's a family doctor who can prescribe something like an antidepressant. But that is the difference, is the ability to prescribe medications and the focus of the training. For psychiatrists, the focus is medicine, and for psychologists, the focus is psychology, psychotherapy.
Righty. One of the students asked, as a high schooler, what is the best way to get local opportunities or to find options to shadow a physician?
I think there are I think there are local programs that have, I want to say Bay Health has as a program. I'm embarrassed that I don't know exactly what it is, but I think they have some kind of, it may be with Del State actually. So that, yeah, I'm not quite sure. I would check around with Bay Health. They do have some kind of like shadowing type program. There are, and I don't want to throw anybody under the bus and volunteer them, but I do know there are a few physicians at Bay Health who take shadowers. I had a person coming from my undergrad who wanted to shadow a bunch of different docs, and I had her go with a few different docs in the health system. So there are people who will take shadowers for sure.
And I would say to all the students out there, a good place to start would be to call up the hospital's volunteerism department and start there. Even just the act of volunteering at a hospital can be a very gratifying educational experience. It's how I got my career started a very long time ago. At the Alfred Upon Institute for Children.
The scribes, I don't know if what you need to have, like if you need to have a bachelor's or be in college to be an ER scribe, but several of my friends in medical school worked as ER scribes. And so, I mean, you get paid, which is great. And a lot of times the ER docs will answer questions about what's going on, and because they're like dictating to you when they're seeing patients, like, they'll say, okay, this is the history, and then you type it in to the computer. So scribing, you might look into a scribe opportunity.
Wow, good suggestion. Not one I've heard of it. I never would have made that association. I think you answered this before, but do you consult on pediatric cases?
I do.
Okay.
I wish I didn't sometimes. And I say that only because it is medications with children is much different than it is with adults. And I wish there was a child and adolescent doc to see our inpatients, because it is it's its own subspecialty. So
Right.
I am able to see children. You are able to see children as a general psychiatrist, but there are some significant differences.
Alrighty, there's one question left that I'm going to ask you, and then another one that came up through a different channel. Would a certificate in child psychology be enough to intern for behavioral health or patient care observing unit?
Yeah, I don't know. I don't know about that. Yeah, that I have no, I would be up to that particular unit about what their qualifications are.
I'm not entirely sure I even know what a certificate in psychology would be based on from an educational standpoint. So
Yeah, I'm not sure.
So during my lifetime, there have certainly been a lot of different common names for different psychiatric conditions. Multiple personality disorder. Now I believe it's what dissociative identity disorder is the more common. Are there any other buzzwords like that that you'd like to tell us to please never say this, say that instead, or vice versa?
Dissociative identity disorder is quite controversial within psychiatry, so I think that's a unique one. The other one that this is, I don't know, I don't think it's really similar, but I know when people say things like when they use bipolar colloquially, just like, every time somebody says they have bipolar disorder, I'm like, all right, I'm almost like in my head, I'm just like, all right, like, let's go through the criteria. Like, I gotta check. I can't take your word for it. I gotta know. Because it's entered the lexicon as a term for mood lability, which bipolar disorder is so much more than an irritable or labile mood. It's so much more than that. It's a very complex and significant psychiatric illness that requires a certain set of medications to treat it. So I want to know that is so. Like I would encourage people to not use it colloquially, to use it to not throw that around, because it's actually an identifiable serious medical illness.
Right. All righty. Well, doctor, thank you very much. Great end to this series. We thank all of our colleagues at Bay Health. And as always, I thank my co-host, Christy Handley, for joining me. Christy, I'll let you off easy tonight with not having to do half of the questions. Thank you all for attending. One of the questions that popped up was, when will we get the certificates? I assume you must have come in a little bit late. Emailed certificates, if you attended less than 6 classes, come out sooner than mailed certificates, which are printed out and put through the US mail system, which is pretty slow these days. That's more like a month. But we'll be sending emails out following up with everyone. Just a reminder, the next series starts on October the 30th. The registration is open. And thank you very much for joining us. Have a good night.
See ya.